little rubber bumper that goes around your glenoid to keep the ball where it's supposed to be. It basically makes the dish deeper, the socket deeper. It's a cartilaginous tissue around the edge of the glenoid, multiple different sites of injury. But before we go to SLAP, and I wish I would have typed out more on this, so once again, we all know that the majority of our shoulder dislocations are where? Anterior, right? So most of your labral tears would probably be anterior, inferior, right? So it usually goes down and out. So, and whenever you get MRIs, what they'll do is if you look at our right shoulder, so if you pulled my arm straight off of my body and looked at my labrum, they number it like a clock. So obviously the top is 12 o'clock, the front would be 3 o'clock, the bottom 6, the back's 9. So what they'll do is they'll say something like they have an anterior inferior labral tear from 3 to 6 o'clock, or 3 to 7 o'clock, or from 2 to 4 o'clock, or whatever. The hard part is whenever you go to the left shoulder, you have to flip it. So you don't go in there going, oh, it's 3 o'clock, you've got an anterior labral tear. Well, 3 o'clock on my left shoulder is in the back, so you got to flip it when you go around. And make sure that the radiologist did too. Sometimes they'll still use the same clock on the other side. So once again, most common is anterior, inferior, coming out just like your shoulder did. SLAP tears stand for superior labrum anterior to posterior tear. These are usually, once again, on your overhead throwers, your quarterbacks that got hit, your baseball pitchers, people who do a lot of throwing or some kind of an overhead activity, because what they do is they stretch out their dynamic stabilizers, their muscles and ligaments and tendons, which makes them put more pressure on the other things to keep everything in check. So once again, these are your 18 to 20-year-olds, your 14, 15, 16-year-olds. I can't remember the last time I saw a 14-year-old with a rotator, or with a labral tear. I'm sorry, rotator cuff tear, excuse me. So once again, dislocations, overuse injuries. Now, once again, so if we go through this here, and I'm trying to do this, so this is your, so imagine this is looking in on your right shoulder, okay? So this is the long head of your biceps, because everybody knows that the long head of your biceps comes in and attaches at 12 o'clock, right? Top of the clock, going around. So type 1 SLAP is whenever you have a tear through the labrum, I'm sorry, a tear through right there above the glenoid-labral interface. This is a type 1. It's almost like a type 1 AC separation. It just kind of does this and makes everything mad. A type 2 is like this right here. You can see the difference in where the labrum stops and the glenoid stops. There is actually, they can call it a drive-through sign. You can kind of go through there with it on that, with your scope. A type 3 is like, I don't know who, well, I'm going to be giving your needs lecture next week, but when you have a meniscal tear, it can be called a bucket handle tear, because if you've ever seen a bucket handle that lays down flat, what happens is when you flip it up and over on itself, so that's what they would call a type 3, which is a labral tear, but the bucket handle part literally flips down in the joint. Those people will come in with a lot of mechanical symptoms. Man, it just feels like something's popping and moving whenever I'm moving my shoulder around. And then a type 4 is the worst one of all, because then it actually goes up and involves your biceps tendon. And that's the grand poobah of them all. Pretty rare. Most people have this, or actually most people have that. Examination apprehension test. Okay, so, and I'll show you this when we go through the exam, but an apprehension test, does anybody know what that is? Okay, so you guys have done the shoulder fist die, yes? No? A little bit? Okay, so an apprehension test. So if I'm standing here and I'm the patient, I'm going to have their shoulder like this, because remember, most of them go where? Out the front, right? So whenever you take somebody's hand at a 9-degree angle and you start doing this, that actually rocks their humeral head out the front. So whenever I'm doing this, you can imagine if I have an anterior inferior labral tear, it's going to start pushing my humeral head up on that tear and forcing it, and they'll start going, whoa, 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 stop, 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 that hurts, right? Or it's going to come out, it's going to come out. I always reassure them if it's going to come out, I've got a bed sheet, back in. They don't usually laugh at that one, but I do on the inside. So once again, kind of coming out like that. So that's an anterior apprehension test. Posterior, all you do is what? Flip it, right? Now I'm going out the back side. They have something called a reduction test. So if you have them, some people do apprehension tests with a patient laying on the table. And so what you'll do is you'll do like this, and if they start to feel it's coming out, what you can do is take your hand here and push it back in and kind of reduce it, and they'll go, oh, that feels so much better, thanks. That's a I don't see any sense in it. If you do this and it hurts, it's that until you prove it otherwise. A jerk test is if somebody's sitting in front of you, you stabilize up here, they stabilize their scapula, and you can literally just take their arm and just kind of translate it back like that. It's almost like an anterior drawer or a Lockman's, but for the shoulder. I don't use that one that often, once again, just because you can flip this one around and not have them sit still that long. And O'Brien's tear is, or O'Brien's sign is it's actually a doctor. I think he's out of Chicago, but he is kind of the one that coined the whole slap thing. And an O'Brien's test, I think I have so there's the apprehension. So, and they get very apprehensive. Please stop, you're going to make it come out. I'm really nervous you're going to make it come out. So that's the apprehension test, which I'll show you. And this is an O'Brien. So basically what you do is, and all of these people have people sitting down. You can do that if you want, but it's kind of hard to do stuff with your shoulders, especially that when they're sitting down. If they can stand up, I have most of our patients stand up. So an O'Brien test, once again, to test for the slap, very, very specific for that. So what you do is you take their arm and you put it 10 degrees across midline like this. Your thumb is down and you push down on it. Then you have them flip it up and you push down on it. And just like it says up there, if the pain with internal rotation decreases with external rotation, then it's a slap lesion. So if this one hurts, and then you do this and push down, they go, oh yeah, it's not as bad. That's kind of one of those. I don't do all of this stuff just because, to me, it's, once again, you already think you know what it is. So my O'Brien's test is I'll do an empty can test and I'll flip it up and push up. Because you can imagine, if I'm taking their humeral head, they're trying to push up, and I'm pushing down, it's going to do like that. Well, if that biceps tendon in the labral complex there, if I'm pushing up on their humeral head, it's going to be doing that, right? So once again, you're still probably going to get an MRI anyway, so that's my positive O'Brien's. But you can do it like this because this is what the book says. So that's a labral tear. So in terms of things, usually on the labrum tears, we fix 2 and 4, and you can sometimes get away with leaving 1 and 3 alone, depending upon if that flapped piece is causing them mechanical instability. If it's a labral tear on somebody who's younger than 40, we will usually fix it if they are symptomatic, mechanical symptoms. I can't put my hand behind my head to wash my hair like that without it feeling like it's coming out, or consistent instability feelings. That's something we would fix. If you are over the age of 40 and you come to me with an MRI that shows you have a labral tear, we will not fix your labrum. Because why? People over 40 were getting stiffer. And so if we stiffen you more, because believe me, if we fix your labrum, it will make you very, very stiff. And the last patient that came to us from another physician who had fixed a labral tear on a 42-year-old nurse that took her 2 years of physical therapy before she could get her range of motion back. So what we would do, and I'm not saying it's bad, it's just something different than what we would do. So what we would do on something like that is, so let's go to this one right here. So imagine this. So if you have somebody that comes in that's over the age of 40, and they have a slap tear and having all kinds of pain, man, I've already done physical therapy, I've already taken anti-inflammatories, I've already had shots, I'm done with this thing, you better do something about it. What we go in and do is we do something called a biceps tenodesis, and that's where we release that biceps right there, the long of the biceps where it attaches, and we tie it in somewhere else. Well, what does that do? It stops pulling on it, right? So if I flex my biceps, that's coming down, and this is my labral tear, and my arm is my biceps, and every time I flex my biceps, it's doing that to that labral tear. Of course it's going to hurt. But we know that if we fix that labral tear, it's going to make you too stiff, so we just remove the offending agent. We move your biceps over, and it's called a biceps tenodesis. A tenotomy is to release, and then a tenodesis is to reattach, or put down. All right, I think we're on the home stretch, folks. Shoulder impingement syndrome, we've kind of already covered that before. Combination of shoulder symptoms that are caused by limited range of motion. Once again, they feel like they hit a brick wall. They'll go, man, it's not that bad, I didn't have an injury, it's just, it won't go any higher than that. Positive Neer's and Hawking sign, pain with range of motion above the head and shoulder abduction at 9 degrees. Once again, this is one of those things that usually gets better with things like icing, anti-inflammatories, physical therapy, steroid injections sometimes, and if not, we go in and we do something called a subacromial decompression. So remember, impingement, chromium, some people's are hooked down, so my rotator cuff keeps hitting it. So what we do is, has anyone ever seen somebody make a table, like plane a table before? You have to make it nice and smooth. So in the operating room, we have this thing, it's a barrel burr, but basically it spins at a high rate. And it basically, we just go in and we trim that hook to where it's straight again. So now I can move my rotator cuff all we want without it impinging. So it's called a subacromial decompression because it's underneath the acromion and we're decompressing. All right, adhesive capsulitis. Gradual development of global limitation, that sounds like global limitation of active and passive range of motion, most common And women with diabetes, people with diabetes after any kind of a shoulder or whatever injury, their bodies like to cramp up like this. So they take their capsule, which on all of us is nice and pretty. Think of a big water balloon, and that's why you can move everything around. And whenever they get injured, either before or after surgery, or if they just have an injury that they didn't address surgically, and they just put themselves in a sling, which happens all the time. Well, I've been like this for 6 months, but now it feels good, but I can't lift my arm up. They've got adhesive capsulitis, or in the business we call it stuck like Chuck. Examination, once again, nagging pain at night, progressive global stiffness. So it's not just stiff in one area, it's everywhere. I can't lift it to the side, I can't lift it to the front, I can't go back like that. And the biggest thing you guys need to remember is that first sentence where it says active and passive range of motion. So let's go back to our rotator cuff tear. What do those people have trouble with? Pain with overhead activities, right? So what happens is if they come in and say, yeah, it's kind of weird, I can't do this anymore, but then if I can take their arm and go all the way up, then it's not adhesive capsulitis because I can go farther passively than they can go actively. However, if I go to 90 and I go, oh, they're probably milking a little bit, and then I take their arm and they can't get past that, they're truly stuck because you'll feel it. It's just like you hit a brick wall. It just won't go anymore. They're not trying to push down. It just won't go. That's adhesive capsulitis. So that's the biggest thing to take home is it's got to be equal active and passive range of motion. If the passive range of motion is bigger than the active, it is not adhesive capsulitis or it's not there yet. Most people call it frozen shoulder syndrome. Treatment, once again, conservative with physical therapy. Surgical arthroscopy with capsular release is sometimes necessary. So the best thing that and once again, bad analogy, but you'll get it. If all of us were standing inside of a giant basketball, the walls are not moving one way or the other. Well, we need them to move out now. So what we do is we take something called a hook probe on an electrocautery unit, and we make little slits all the way around and basically turn it into perforated paper, the capsule, which allows it to expand. Kind of like that thing where they do that with the paper and then they have 3 dolls that come out. That type of a thing, but we do it with your shoulder without the dolls. And so what happens is, and whenever they come in, they have a limited range of motion, but they leave the operating room with full range of motion. And so that's the hard part for people to turn their brain around in. They come in stiff. Man, I've already done therapy. I've done all this stuff to try to loosen myself up and it hasn't worked. Well, now after the operation, we check you in the operating room and you've got full range of motion. Now you got to keep it. Because remember, especially if they're diabetic, the first thing their body's going to want to do is what? This again. So you have to keep them moving. So we actually put them in 5 days of physical therapy after we do something like that for the first 2 to 3 weeks. They only get 2 days of rest because if you let them sit still, it's going to go right back where it is and you're going to go right back to the operating room. Manipulation anesthesia, some people call that the barbaric way to do it, but basically that's where you let them get a little bit sleepy and you literally take their arm and you just start twisting it backwards and then you start twisting it this way and you start pulling it like that and you can literally put your hand on their shoulder and it feels like somebody's ripping fabric. You can just feel those adhesions ripping in there. Some argue against that because it's not as precise. Well, how do you know you're not hurting somewhere else? So that's kind of, I don't want to say an older way of doing it, it's just a different way of doing it. A lot of people nowadays do the surgical arthroscopy with the capsular release. Okay, and I think that is all I have for most of this. Do you guys have any questions before we run through a quick exam? Oh, that was the beauty of the last lecture today. Nobody wants to ask questions because then the other people will haze them afterwards. Okay, so who wants to? You want to come back up here again? Can everybody see basically? Okay, so here is mine. So if I go into a room, oh, before you get up here though, you can come on up. So orthopedics, I kind of make it very, very easy. I always tell people no matter what happens when you come in our office, you've got 5 options. I don't like being told to do, so I'm not going to tell you what to do. That goes back to the whole, I'm going to sit on the same level as them. If I come in and start going, here's what you're going to do, here's what you're going to do, here's what you're going to do, even though I know the right thing to do, it's easy for me to say go get an MRI. They may not have $1,200 for an MRI. So always give them options, and this kind of goes back to the PA philosophy thing, because if you let somebody help you out with their health care, it does a couple of things. Number one, it means you respect them and you actually care about their opinion. Number two, it actually shows that you're listening to them and what they want to do. And number three, it kind of covers your rear a little bit because if they come in going, by golly, I want an MRI come hell or high water, you get an MRI and it's normal and then they come back going, dude, that was a lot of money. Why did we get it if it was normal? Well, We made that decision together. In fact, you came in telling me you wanted one, so you really can't be that mad. So here's our 5 options. No matter what is wrong with you, whether it's a rotator cuff injury, if you have a bone sticking out of your head, whatever. 5 things. Do nothing at all and see if it goes away. Most people, by the time they get to me, that's gone. Icing, anti-inflammatories, and physical therapy. Whether the anti-inflammatory, we do a lot of the creams, the compounding stuff right now is kind of becoming kind of cool. 3rd option is an MRI. The 4th option is an injection. And the 5th option is surgical intervention. And so a lot of times what they'll do is, so let's say that you came in and you said, okay, I was helping my grandma move and I lifted this couch and man, my shoulder's kind of bothering me and I kind of think I did something to it, it hurts me to sleep on it. I'm already thinking rotator cuff tear, right? Because somebody just said that I was helping move something, I'm over the age of 40, and I can't sleep on it. So it's probably going to be something with my rotator cuff. So then I would say, okay, well you don't want to ignore it because you're in here talking to me. We can do any of these other 3. Probably don't want a shot right off the bat, and most people don't want surgery right off the bat. So then you've already narrowed it down to 2. Now which one do you want to do? And then they'll go, well, to me, the MRI kind of sounds expensive, so why don't we start off with the icing, the anti-inflammatories, and the physical therapy. Wonderful, let's try that. Now come back and see me here in about 2 or 3 weeks. We'll see if you're 30 or 40% better. If you're not, we'll go get an MRI. Okay, sounds good. They come back, man, I'm better. Great, glad we got you better. Have a good life. I'm not better. Okay, let's go get an MRI. So if you'll let them become involved on their health care, I promise you people will respect you a lot more because number 1, they're listening and you're listening to them. And number 2, people like it when they get to make decisions. People don't like being told what to do, especially when it comes to their health, especially if they're painful. People hate that. If they're painful and you come in there barking out orders, that is not going to go well. And also, it's their money. Nobody likes being told what to do with their money. So that's the nice thing about it. Okay, so anyway, my rant. Okay, so stand up here for me. So face that wall if you don't mind. So this is my slimmed down shoulder exam. So the first thing I'll do is, and this is kind of a cool thing, but if you put your finger on their AC joint, does that bother you at all? If it hurts, AC joint. Doesn't hurt, not AC joint. If you will put your middle finger down, on most people, you will be on their coracoid, what attaches to your coracoid? Anybody? Short head of the biceps, right? So biceps tendinitis comes up and splits. Short head, long head, remember, goes down in on the picture there. So AC joint, coracoid, short head of the biceps, and then put your index finger down, long head of the biceps. So you just hit 3 things right like that. So AC joint, coracoid, long head of the biceps. So then you go right into NIRS. So if you'll relax for me. So we'll come up. So a normal exam would be him going all the way up. A positive NIRS test would be us going right here and him going, yeah, right there, that's kind of pinching something there. This is Hawkins. So once again, keep their hand away from their face and have them relaxed, and this is a Hawkins test because it's parading that underneath their acromion. This is a crossover test. Like this. Usually I'll put my hand right here. Some people need kind of some guided stuff. And I'll say, put your hand on top of my hand and we'll go over like that. Is this awkward for you? Alright, so then what I'll do is I'll say, okay, turn and face me now. Now take both arms straight out in front of me, go all the way up in the air like a Superman. So what's that? Forward flexion, right? Okay, so back down. Act like you're doing a slow jumping jack. Okay, so there's abduction. Put them right like this for me. Keep your elbows glued to your side and roll them out. Which rotator cuff muscles do that? I like how everybody does it too. Think about it. Flying, little birds. Anybody? Shame on you all. Okay, so external rotators. What external rotates? Okay, come back to me on that. All right, so that's external rotation, and then walk it up your back. So T12. So whenever you put your thumb in the middle of your back, most people are at T12 if their hand is parallel to the ground. I call it the bra strap level. If girls can get to their bra strap, that's normal. We actually had one lady that came in the other day and she could literally do this and touch the back of her neck with her fingers, which was super creepy, but abnormal, because then they think that's normal. So even if they can get to here, this is abnormal for them. So once again, I usually compare both sides. So do this again for me. Okay, so there's internal rotation. So we just tested forward flexion, abduction, external rotation, internal rotation. Okay, so put them back out here again. So this is where you go start testing the rotator cuff. Has anybody found an answer to that yet? Okay, good. Last time I brought gifts. I'll bring them next time. You would have gotten one though. So push out against me. So right, so you're testing both sides. So there is infraspinatus teres minor, right? Okay, now push in like you're clapping. Go in. What does that test? Subscapularis. There you go. Okay, so push up. What does that test? Oh, come on, what do you do with this curl? It's for mine. All right, don't overthink it. Biceps, right? Okay, push down. Okay, so there's your triceps, right? So you just tested rotator cuff, biceps, triceps right there. So once again, and this is not the perfect way to do it. I mean, I like it because I kind of was taught this and have kind of made my own deviation. But it's what you want to do whenever you're working with a patient. They hate it if you have them sit down. Oh, I forgot something, stand back up. No, I forgot, lay back down. You want to make this as fluid as possible because number one, you usually don't get that much time with the patient. And number two, if you keep moving them around and they're hurting, they're not going to like you very much. So then I go straight into empty can. So thumbs down. Like I said, test both sides. So push up. So remember, 3 things. So if he has no pain and no weakness, what would it be? Normal. So if he has pain and no weakness, what would it be? More than likely. Tendonitis, partial thickness rotator cuff. If he has full, I can push it down. And usually, I mean, and even, I don't care how big people are, they can be a bodybuilder, and if they have a torn rotator cuff, I can take them with 2 fingers and push them down. Because there's nothing, because this disengages everything else. So if that's torn, that tendon's going, whoa, 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 I can't, and it just drops straight down. So that's empty can, okay? And then turn it up, and that's O'Brien's, and my O'Brien's, which I think it works. Okay, so then turn and face this wall right there for me. Now this is where you just relax. And then I would take his arm like this, and you just start going backwards. And if he starts going, whoa, 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 this hurts in the front, it feels creepy, it's going to come out, obviously stop, and then go to the back, and then go down. So that's a whole, so in real time, it would literally be like this. So AC joint, coracoid, long head, the biceps, Neers, Hawkins, cross over. Okay, now turn and face me, take both of your arms straight up in the air. Okay, now do them like a slow jumping jack. Okay, put them to your side and roll them out. Walk them up your back for me. Put them back out here in front of you. Push out, please. Push in, and then up, and then down. Okay, bring both arms out like this. I always feel like we're dancing when we do this. Push up towards the sky. Palms up for me. Now push up. Okay, if you will, face that back wall for me. Anterior, posterior apprehension. You just did everything, just there, right? So, and if you get good at it and it gets fluid for you, and like I said, do it however direction or order you want to do it, but that's the whole shoulder example. Critique now? So, you guys don't have any questions, seriously? You guys knew all this stuff already, or you just tired?
A little bit of both.
Well, thank you for having me. Thank you for demonstrating, by the way. I guess I'll see you guys next